morning, good afternoon, wherever anyone is. It's really a pleasure to be with you all. Siam and I had been talking about today's presentation. I know this is the beginning of this series. And I did do this once before, and it seemed to generate a fair amount of interest. And so what I want to do is talk about, if I do my clicking correctly, there we go. Can you see all that the presentation slide?
Yeah.
Yeah, everything looks okay to you all. Talk about what global health is and my journey into how did I get here? Because it all has a beginning to the start of this story. And it's a continuing story. I'm still evolving and learning. And I think all of you have just experienced and are continuing to experience a pandemic of unbelievable proportions. And that's the COVID-19 pandemic. And I'm going to end my talk on that because that's what's most relevant to all of you right now. You've all heard the debates about vaccines and wearing masks and so forth. It's been very domestic oriented, but this pandemic isn't just the United States. It's every country in the world. It truly represents a global pandemic. And you've seen its origins. You've seen the politics intersect with public health. And you've seen the development of vaccines. It really is the most relevant story I think we can lead up to and end. But how did I get into global health? Because many of you are thinking about your future careers and whether you might be interested in something like this or not. So let me start it, at least in my beginning, which really happened in college. And I was taking a course, and I ran across in this course on parasitology. That was the name of the course. It was being taught by this individual you see on your screens, and that's George B. Craig. He was a professor of biology at the University of Notre Dame, which is where I went to school. And although I had been toying with the idea of going into medicine, it was really when I met this individual that I got very excited about biology as a whole. Yeah, I liked it in high school. And I took some courses in college, but when I was a junior when I met Dr. Craig, and I just, his enthusiasm and his excitement just really got me going. And by training, he was an entomologist. So he studied insects primarily, but he studied mosquitoes as vectors of disease. And the disease that was the largest killer at the time globally was malaria. So was yellow fever was still a scourge. Other types of viruses were being spread by mosquitoes. And so it intersected biology, vector biology with medicine. So I actually asked if I could work in his laboratory. I got very excited about some projects with him. And in fact, my very first publication, as you can see, just the two of us, worked on genes in mosquitoes that could be manipulated, create a mutant. The mutant was called Proboscipedia, the mosquito's Aedes albopictus, which spreads filariasis among many other diseases. And when you mutated the mosquito, the proboscis, which is in this photograph over here, actually becomes deformed and it can't bite humans. And so it was a non-transmissible vector. But we were very excited about this. We published it in the Journal of Heredity. But at the same time, I picked up my master's on this project and master's in science. I also got accepted into medical school, which had always been an interest of mine, how to intersect, again, biology with medicine. And so I went off to medical school. Well, I went off to medical school at Northwestern, and I met one of this mentor, my mentor from college, George Craig, was one of his former students. And his name was Michael Dunn, and another student of his, Henry Turwido. And we're now working as medical students in Northwestern University. They gave us a little lab. You can see we continued our relationship with the vector biology lab of Dr. Craig's, and we worked on malaria. So I was moving bit by bit into the field of infectious diseases of a global proportion. Of course, it wasn't called global health back then. This is all what was termed tropical diseases or international health, all of these terms being interposed. The word or the terminology global health doesn't appear until much later in the literature, and we'll get to that. So I did my training in medical school. I went off and became a resident, but I missed that excitement of laboratory medicine and malaria and some of the things I had been working on while I was a student. So I asked to do a fellowship at the National Institute of Health. And I wanted to work on malaria and learn more about how do some animals, in this particular case it was rodents, how do they clear it without treatment? They actually get exposed, but they don't die from it. And what could we learn about that we could then apply to humans? And because malaria was developing resistance to the anti-malarials, chloroquine at the time. And in fact, it's almost all now completely resistant. Well, we devised some studies, and we would chromium label infected red cells, inject them in the mice, and the mice would sequester them all in their spleens. They would develop antibody and other types of immune responses and clear it. We did transfer of that antibody, and I started to learn more and more about immunology. So here I am at the end of my medical training, working as a fellow, and I needed to get certified in infectious diseases if I was ever going to really do something globally in some of these diseases. So I went to the University of Washington in Seattle, and I met this individual. And I'm focusing on these mentors because all of you entering your careers over the next 2 to 10 years, whatever your time frame might be, mentor is going to be the person who helps shape you. Yeah, I mean, most of it comes from you and your own drive, but you need a guiding force of someone who's gone through it. And we call those mentors, and there are good mentors and there are outstanding mentors. King Holmes was the individual I trained at the University of Washington. He was a force in the epidemiology of sexually transmitted diseases, both epidemiology and in biology. And he linked me up with other professors at the University of Washington. And one of the projects I worked on with him was called Chlamydia trachomatis. That's the most common bacterial sexually transmitted disease. In the United States, it can infect anywhere from 2% to 10% of young individuals who become sexually active, and it can cause infertility. It's in a way, a very dangerous organism in terms of reproductive health. And it's global. This is not just a domestic disease, it was international. It was just that Dr. Holmes didn't really work on malaria. He allowed me to keep doing my malaria, but he said, I got a bigger global problem for you. Happens to be reproductive health. And when I learned about this life cycle, and I'm not going to go into any of this isn't a science course per se, but it is a 48-hour life cycle within columnar epithelial cells. Well, malaria is a 48-hour life cycle in red cells, and they go through very similar types of changes in their biology when they infect their host cells. And so for years, I worked on this, and I owed my early career to these two mentors, Dr. Craig, who really got the excitement and enthusiasm of biology into me, and then King Holmes, who really got much of the intersection, once again, of biology with a global health problem. I will cut to what's happened to these people. Well, Dr. Craig has passed away, but he became a member of the National Academy of Science. He really rose to the pinnacle of his field. Dr. Holmes is now Professor Emeritus, but was the first chairman of global health at the University of Washington. And he continues to this day in a very active way. But if you were to ask him now what was his major passion, it would be mentorship. He's very proud of all the people that he mentored in their early careers. And I'm indebted to him for much of that training. Well, here I was, I finished my work with Dr. Holmes. I was looking for a job. I landed at Johns Hopkins as, starting out as an instructor, bringing my strength of parasitic diseases, sexually transmitted diseases, and immunology. So you can see I brought together, several different areas of expertise, but right at the time I started at Hopkins, and I'm dating myself here, it was 1981. I started July 1, 1981 at Johns Hopkins, and we were getting these reports from what's called the Morbidity Mortality Weekly Report. These come out every week from the Centers for Disease Control. They're little reports as to what's going on in the field of epidemiology, infectious diseases, cancer, auto accidents, gun violence, all sorts of things. But that week that I started at Hopkins, there was a report of 5 young men who were gay, homosexually active, who acquired a very rare pneumonia caused by an organism called Pneumocystis carinii. And this was being reported in California, and everyone sort of said, it's only 5 cases, this will die out. There wasn't a whole lot of attention other than this is very unusual, and why is it in gay men? But just 3 weeks later, a month later, there's another report. And in the MMWR, I put their 2 titles on this one slide. And that report was 26 homosexual men, 20 in New York City, 6 in California, that developed that same pneumonia, Pneumocystis carinii pneumonia, but also a very rare, hard to ever find, cancer called Kaposi sarcoma. So no one knew what was going on or where this was headed. We called it gay-related immunodeficiency because these were diseases of immunodeficiency. But notice that they were homosexual. So the question of sexual transmission came up, and I just spent 2 years studying sexually transmitted diseases. It was immunodeficiency, so there was something going on with their immune functions, and I had done all that immunology with malaria. And there was this cancer and other things. So here I had that training. I was very interested in what was going on. And what soon became very, very clear is that this was 100% fatal, no treatment. Everyone who acquired these diseases died. It became one of the most feared diseases of our time because at the time, we didn't know what was causing it, and we didn't know why gay men were getting it. So this truly was a disaster in the development. And here's its time frame in that first year and a half of the disease. Now, we're talking 40 years ago, if you do the math, and we've learned a lot since. But you have to remember, I'm now a brandly minted doctor that has an appointment at Hopkins, and these cases are popping up on our ward. And we needed to find out what was causing it. Well, there were a couple epidemiologic findings that were very clear. It was occurring in hemophiliacs who were getting blood transfusions, other people who were getting blood transfusions. So we knew it was blood transmitted. We saw it in infants that were being born to mothers who also showed signs of the disease. So it looked like it was heterosexual and perinatally transmitted. But the one thing that we could not explain was this first one up here. Why was it occurring in Haitians? That was they were being criticized and stigmatized that they might be the carriers of this disease. So what do? Who's now been very interested in this, and I see it's coming from Haiti, the Haitians living in the US. So I was fortunate enough to know the director of the Institute, National Institutes of Health, where I did my fellowship training, if you recall. And he wanted to find out what was going on. He invited me. This is a young me. You can see I don't have any gray hairs there. We all do start out at a young age. And we flew down to Port-au-Prince, Haiti, and we started to do an investigation down there. You can see our paperwork. We're going over case reports. We went on the ward, and this is one of their wards. They had run out of beds. They were all just being pushed into different areas. And we were finding that this disease that we saw in gay men predominantly in the US, although we also saw it in some women, some babies, it was heterosexually transmitted. This ward has both women and men in it, and was just hitting all these individuals and killing them. Remember, we don't know what's causing it yet. We still don't have a diagnostic test for it. And certainly no treatment, not knowing what was causing it. So for 3 years, the hunt was on to try and find out what caused this horrible disease. But we did this report and we found out, okay, this is heterosexually transmitted in a country like Haiti. What about other countries? And there were some anecdotal reports of a similar disease. It was called Slim's disease that was being reported in Africa. And so 6 months after being in Haiti, I found myself again with my colleagues We flew into Kinshasa, which was called, the country was Zaire. It's now called the Democratic Republic of Congo. And it was notable back then as being a place where Ebola had been identified. And those anecdotal reports were of people who had gone to Europe and diagnosed as having what looked like AIDS, but had come from Kinshasa. So we went into Kinshasa. We went to the largest hospital there, Mamiemo Hospital, which had 2,000 beds. It was the largest facility I've ever seen. And I set up an epidemiologic investigation. We collected blood samples. And at the same time we were there was a report in Science, and it's why it's so important to keep in touch with what's happening in the scientific field. And there was a group of investigators in France who had recovered a retrovirus from a lymph node of individuals with this disease. They called it LAV, later was renamed HIV, which all of you know is the cause of AIDS. Well, we had collected samples. We wanted to know, is it the same virus then that's causing this disease in Africa that we see in the US and they see in France? So we collected the blood, we sent it to them, and lo and behold, every case that we diagnosed clinically as having this disease called AIDS was positive for the virus. Those people in France ended up just a few years ago getting the Nobel Prize of Medicine for the compilation of that work. So it was really cutting edge science at the time, but it took us 3 years. This will all become relevant when we get to COVID very shortly, because what took us many, many years to really identify the pathogen for COVID, the pathogen was identified immediately, and we'll get to that story. Here we were in that hospital, 2,000 beds. Everyone in this picture was afflicted with the same disease. They were all positive for that virus. So we reported that. It's very important in academic medicine, if you're doing these investigations, is to get it into publications so that people can learn what you're doing. If you don't report it, they won't know it. It won't have any impact in the public health arena. So we did report this in the Lancet, and I just highlight one sentence from this report. But if you're interested, it's a fun report to look at for the beginning of a disease. And basically, we said the situation in Central Africa represents a new epidemiologic setting for a worldwide disease, significant transmission in a large heterosexual population. Because back in the US, it was all about gay men and occasionally in some blood transfusions. But we saw a bigger picture of a world. You notice we don't use the word global in this situation because, again, that hadn't really come into vogue yet. So we continued our investigations. We formed a team. We worked very closely with our African partners, all of them outstanding people. And we worked with, here I am in the middle over here, but all of these individuals were just outstanding collaborators that I had an opportunity to learn from. It's interesting when you look at some of these people. This is Jim Curran, who was my partner in the development of this program. He just stepped down as Dean of the Emory University School of Public Health. He may still be active with some of that, but I've understand understand that after 20 years, he has stepped down from that. This is Peter Piot, who I trained with in Seattle, who then became the executive director of UN AIDS, was the deputy director of the United Nations. Just an outstanding person. We have Jonathan Mann over here, who headed up the first World Health Organization task force and group on working on AIDS. And I can go on, all of these individuals, just outstanding in their own right. And that is the second lesson. So I talked about mentorship. The second is collaboration. That to do this kind of work globally, you need to know how to collaborate, how to share in both the work as well as the fruits of that work, the knowledge that you gain. And you must equally share that with the host partners in this case, my Zairian partners. This is Bila Kapita, and you can tell now, 40 years later, I remember all their names because we just formed such a bond. He was chief of medicine of that Mama Yemo Hospital. Ann Nelson, head of pathology at the Walter Reed Research Institute. John LaMontagne, who's blocked a little bit back here, who headed up microbiology and infectious diseases at the National Institutes of Health. So I could go on and on naming everyone, but collaboration is the important message. If you're going to do anything globally, it's got to be a fair, equal partnership with all of the individuals. It's not just the people in the country where you're working, but also your counterparts coming with you from your university or some other entity. Well, along the way, we compiled a number of studies, and I'll just highlight what we forecasted. And this is 1986, that prevention and control of this new disease, HIV, should be the immediate public health priority for all African countries. We just saw this as an explosive pandemic. Unfortunately, it was denialism seemed to prevail in Africa during some of this time. This is HIV prevalence, the percent of the population that's infected with the virus. This is 1992 down here. Sorry about the change in the graphic here, but you can see it just skyrocketed up to almost 1 out of 2 people being infected. This is the mothers who were pregnant coming in to the clinic we were working in Swaziland. I started to work in a lot of different countries during this time because it was just incredible that this disease was just skyrocketing. Towards the end of the 90s, we had learned how to diagnose and treat this disease in the United States, but none of those drugs had reached Africa. And we ended up seeing an inequitable situation that was untenable, could not continue. I took this photo with everyone's permission in a clinic in Kampala, Uganda. It was a dark, dingy clinic. All these people online to get something to treat their AIDS condition. And there was no treatment. It was the most depressing situation I had been faced with. I mean, it was scary in the beginning when we didn't know what was causing it. But once we could find out how to diagnose it, we had the pathogen, then the biology went to work and we started to develop drugs. Science will follow those leads, and it did, but ended up too expensive for the poor countries of the world. So we had to witness literally thousands to millions of poor Africans dying of this horrible condition because they were denied access to treatment. I'll never forget this photograph that I'm just showing. This was on the cover of Time magazine and the New York Times. These are 3 orphan children sitting on a freshly dug grave of their parents. 2 of these are infected with the virus, and it will fall upon this young sibling to take care of these 2 orphans at that age. Just horrible disease. This also from the same article, just showing how the wasting that occurred. And yet there was therapy in the United States. If you could get those drugs to Africa, you could maybe make a difference. Well, that's when year 2000 hit. That we were all seeing this inequitable situation, and this pandemic of AIDS that was all over the world. We'd dealt with it in our own country for 2 decades, but Africa was feeling the burden of it. 60% of all the cases were now occurring in sub-Saharan Africa. And truly, developmental gains in those countries of 3 decades totally reversed, economic declines of 10 to 40%, health systems in absolute chaos, political instability, security concerns, increasing numbers of orphans, which I showed you, just huge humanitarian concerns. And yet there was an answer, and the answer was treatment. That there could be, if we all acted together, a way of reversing those horrible trends that I just outlined. And so I call this the year of 2000, the international response, because the pressure of the world came back to the US and to Europe and the rich countries of the world that you've got to do something. You just cannot allow this to continue. And so we all went to the United Nations. We formed a declaration of a commitment on HIV/AIDS, the first one that has ever been done. And we did this in the Security Council. We got endorsement from our leaders of our country and many other countries to really back this. And back then, you count that backing in terms of dollars. I hate to do that, but you can't do anything without the financial support of these countries. And you can see in 1996, when UNAIDS was initially formed, only $300,000 $300 million were allocated for the entire AIDS pandemic. And that poked along until year 2000, when the Bill and Melinda Gates Foundation decided to get engaged, and then the World Bank decided to get engaged. Then we had some force in which we could do that declaration of commitment. And by 2002, they formed the United Nations, and the World Bank formed what's called the Global Fund for AIDS. And then President Bush, formed a program called PEPFAR, Presidential Emergency Plan for AIDS Relief. $5 billion out of Congress to Africa. So what you're witnessing in this evolution is the development of what we call global health, the commitment of the world to actually reverse deteriorating health trends to improve the health outcome of everyone, equity being at the base of that. So where are we today? We can treat everyone. The money and the funding are there. The biggest obstacle there is diagnosis, finding out who in fact is infected, and getting people to come in, because it's still a stigmatized disease. But if we can identify everyone, we now have the resources to treat them, and it is inexcusable that someone should be denied treatment. And treatment equates with decreased transmission and survival. You will not die from AIDS as long as you're on treatment. But unfortunately, if you can see the top of the slide, if we look at 2020, just before the COVID pandemic interfered, we had, over that 40 years, 76 million people had been infected. People living with HIV, it's 38 million globally. 60% of them in the shaded, the darker the red, the higher the rate of infection. 60% of those people living with AIDS are still in sub-Saharan Africa. Each year, about 1.7 million people become newly infected. And still each year, we see about 690,000 deaths. That is, and I will insist upon that, that's inexcusable. These people should be treated. It is a way of getting out there and diagnosing it. I still work in South Africa and in Uganda predominantly, and I can tell you we are diagnosing close to 90% of the people and getting them into care. We need to get that to 100%, and we're working on it. Now, why did I spend so much time on AIDS? One, it's my career. It's where I really have worked. But this response, PEPFAR, Global Fund, UN AIDS, it started to, from a grassroots level, come up with a new terminology. We didn't want to call this tropical diseases anymore because it existed in our own country. That's not tropical. And what is local can be global, and what's global can be occurring anywhere in the world. And so it sort of was just grassroots that the terminology of international health or tropical diseases went away, and we ended up with the terminology of global health. This is Science magazine. That's sort of our premier journal in medicine. And this is its cover. And again, any of you who are interested in learning more about global health, this is a great issue. Fantastic. And it's called The New World of Global Health. So that's for the scientists in the world. For people in the general population, that might read Time magazine, they dedicated an issue. It's actually the same year, 2006. And you can see special report on the world's most dangerous diseases and the heroes fighting them. It changed the paradigm of how we work in this field, that the attention of the world is now focused on health as an equity issue. So now we're to the meat of the discussion, and I'll go pretty quickly here. What is global health then? Well, we define it, we publish this in Lancet. It's an area of study or research and or practice that places a priority on improving health and achieving equity in health. That's the 3 words you must remember: equity in health for all people worldwide. It can be in your neighborhood, doesn't have to leave the United States. It can be in Canada, could be in South America, could be in Europe, could be in Asia, Africa, wherever. So we try to give it a focus on transnational health issues. Solutions is where the focus has to be. It's one thing to study it, but you got to come up with answers. We believe in many disciplines being involved. Interdisciplinary, here's my word, collaboration. synthesis of both population-based prevention, individual level clinical care. Anyone can get engaged and work in this because you will bring your own enthusiasm, your own interests, whatever expertise you have developed, whether you're a sociologist, economist, physicist, a medical oriented person. We all need to work together because some of the solutions will require unique approaches. Here's back in 2006, The Lancet, health is now the most important foreign policy issue of our time. As you can have experience with COVID, I mean, some country reports they have COVID, they shut down the borders, there's this a political backlash. It really is a part of politics now, unfortunately, as well as foreign policy. And health's the largest sector right now of the world economy, probably greater than the 10% I'm showing here. I mean, look at what COVID has done to our economy. There's many other, I'm focused in infectious diseases, but some of you, if you go into medicine, might get engaged in other areas. Global health embraces all of these factors, whether it's obesity, mental health, accidents, injuries, trauma, child health, aging, diabetes, nutritional factors. We try to keep count of the number of annual deaths. We're making an impact. If they're going down, people are living longer. And we have a term, if you become an economist or want to look at, it's disability adjusted life years lost. So within a country, if you have a major disease epidemic that causes disability, you can actually quantify that in terms of numbers. So what is global health? What are the root causes of disturbance to that health equity of the world? Well, number one, from my perspective, is poverty and social inequality. And we could spend a whole hour, even a whole day, talking about that, but we don't have time. I just want you to know about these determinants, whether they're being published in New England Journal of Medicine or Lancet or wherever you might see it. So that's number one. Two is human demographics. The population has exploded and is continuing to explode in poor areas of the world. So now we've got overpopulation intersected with overpopulation. We also have exposure into animal markets where quite clearly animal diseases can be transmitted readily to humans and then human to human. We combine those two factors with the ease in which we travel around the world. Global travel can transmit a virus faster than any other time in the history of mankind. You can acquire it over here in one country and be here 12 hours later, transmitting it in New York City. And all of you are concerned about climate change, deforestation, the depolarization of our polar caps, the air pollution, many things, all contributing to climate change. These are all the root causes of health inequities. And so we need to change those. And the focus of today, if I say today in 2022, is really focused on climate change. But do not forget all those other root causes. Yes, climate change is a global health threat. And we do need to address it. And it's getting lots of attention, but it's slow to change. This is just focused on if you don't believe in climate change, you only need to look at these temperature curves dating back from cores of ice and other types of temperature measurements from year 1000 to year 2000. And you can see it has steadily risen over the years, especially in the new millennia that we deal with. Let me just move from that. And when you work in Africa, you can see some of the effects of climate change on nutrition, malnutrition. And as malnutrition escalates, we see more immunosuppression and people dying of other diseases. So I'm getting towards the end. I'm cognizant of time. I sort of want to move away from AIDS and those things and come back to, I do infectious diseases. Yes, I have focused on HIV. Predominantly, here's HIV, this little bug right there. But all of these, and I borrowed this from Tony Fauci, who is a household name these days. He's my boss at the NIH. Look at all these. This is all over the last 10 years of newly emerging diseases, re-emerging, resurging diseases, even deliberately emerging. That was an anthrax, a bioterroristic episode. And this is going to continue. I picked a disease that I thought we could do something about with our antibiotics, and all these bugs are developing resistance to our antibiotics, and now that has become a global health threat. These are just selected diseases between 2014, 2019. I'm coming up to 2020, and you know what happened in 2020. But these are all resurgent diseases that we've had to deal with in just the last 5 years. But then comes along 2019 in China, and then eventually emergence of a global pandemic. This is the timeline of those early events of the new coronavirus. We called it an epidemic in the first month, but then it became a global pandemic. And you can see we found out about it in December 31. People suspected it was coming from China, but by January 10th, 10 days later, they actually had sequenced the virus causing this. Remember, it took us 3.5 years to find the pathogen that caused AIDS. That was 100% fatal. Here, it took 10 days to sequence it completely, a complete molecular sequence of the virus that caused this new pneumonia that was starting to spread across the world. What about the US? Here's the daily trends of number of COVID cases reported to CDC. Look at these numbers, 84, rounding up, 84 million cases in 2.5 years. In the last 7 days, we've had 660,000 cases. In 7 days, we've had 1 million deaths. Just a terrible number. And you know about our different surges. Here, that was the Omicron surge, but it's worse for the world. That's why it's called a global pandemic. Here for the world, you can see we've had 530 million cases. We're soon going to be hitting 1 billion, and 6 million deaths. I mean, this is truly a global disaster. Keep calling it a global pandemic that's now going to become an endemic disease. The interesting thing about this is that the world, just like with AIDS, responded. But now we had the technology to respond quickly. And by the end of the first year of the epidemic, we had a safe and effective vaccine to prevent death as best as we know. Does it prevent the disease? We found out from Omicron, it's not 100% preventative in terms of getting infected, but these vaccines do in fact work. And they're not brand new. The reason we were able to come up with it within a year of identification of the virus that caused it was because it was already being developed for MERS, another coronavirus, and the common coronavirus, and respiratory syncytial virus. Everyone thinks this was a brand new vaccine, but actually the scientists had already been working on coronaviruses, other ones, and related viruses that come up with a safe and effective vaccine. But my goodness, did that take off? And the key is back to global health. So we talked about AIDS treatment, getting it into Africa. What percent of the population of Africa do you think's been vaccinated? I'll let you come up with your own percents. It depends what country you're in. But if you took the whole continent of Africa, you'd be less than 15% of the population's been vaccinated. What about the US? We're at about 70% have been vaccinated. The other 30% don't want to be vaccinated, but that's their choice. That's what they've decided. So there's really some interesting issues in equity. If they don't want to be vaccinated, fine. Could they take the vaccine that they were supposed to get? Could they travel to Africa and give it to an African that could benefit from it? Could they work in the hospital if they're not concerned about this disease that has ravaged many hospitals throughout the world? I try to get them engaged. If they don't want to be vaccinated, then help us with the problem in some other way. And you know, they may want to do that. We just have to open their doors for it. So you might think that's it. We're said and done with global health. There's the picture of infectious diseases. Well, wrong. It's why I went into this field. It's just absolutely fascinating, and there's something coming along every day. This is monkeypox. We have now over 550 monkeypox cases globally, 30 countries. This is not a major threat. I don't want to scare anyone, but it is taking advantage of a niche that our successful vaccine against smallpox has perhaps maybe opened up. Not a lot of people that are immune because they didn't get vaccinated because we eradicated the disease. And there wasn't any really need to get smallpox vaccine. But now monkeypox has emerged, and we as clinicians have to be cognizant to recognize it, to get it treated. And if it becomes a bigger problem, stay tuned. You may be hearing more about vaccination against this disease. So let me stop there. I took you on a tour of the evolution of global health, evolution of my career. And if there's time, I'd be glad to address any of your questions. Thanks.
Well, thank you so much, Dr. Quinn, for the wonderful presentation to open up our conference. We greatly appreciate you taking the time to share your story, insights, advice, and teaching us so much. We do have a couple of minutes for just a few questions.
Hi, Dr. Quinn. My name's Ayati. I'm in 10th. Well, I'll be a junior. I'm technically, I guess, in 11th grade now. Yeah. And I'm from California. And first of all, thank you for coming. It was really nice hearing you and your discussions. And I wanted to ask you, you talked about vaccine inequity and really just like inequity in general in health and global health. And what kind of changes do you think we could make? And what kind of changes would you like to see in the legislation to address this type of inequity?
Yeah, so in the US, there isn't much inequity because it's open to everyone, right? There's no charge. You know, if you're in a certain age group, let's put it that way, you can go and get vaccinated at your local pharmacy. So I'm not worried about inequity of access to vaccine in the US. But once we go outside the US, there it is. Those countries are being asked to buy their supplies. Well, they don't have the money. or they don't have the corrupt politicians that don't want to spend the money towards that. And there is, through WHO, there are agencies that procure through international donations vaccine that then get distributed appropriately. And this is true for childhood vaccines, measles, chickenpox, other types of diseases as well. The biggest donor, you should be proud to hear, is the United States. Not only do we provide the greatest number of dollars, but also donated vaccines, because we have now an excess of vaccines, in this country. So we are contributing. So we're not really part of the problem. The Congress and the president, current administration, or even in the previous administration, they understand that. But it always helps to keep a grassroots pressure on them, because they lose interest pretty quickly. So lobbying is important. Writing your representatives is probably the best way of getting through. And if you can access, look, just go online, put on Uganda. There's a great website called World in Data. Just World in Data, www, whatever. Go in there, type in a country, and it'll tell you how many people have been vaccinated, what percent of the population for that country. Some of those are friendly countries. We're not at war with them or anything. We should be reaching out and helping them. And the only way is to influence your congressmen, congresspeople. Thank you for the question.
I'm Fahmida. I'm from Dhaka, Bangladesh, and I'm a rising senior this year. So my question is, Dr. Quinn, as you mentioned, you have been to different countries for your research work, for example, Kinshasa. So have you noticed any kind of skepticism or fear among the people in those underdeveloped or developing countries about sharing communicating their problems with researchers who come from different countries, especially from the global north?
Absolutely great question. And I'm going to go back to one of my comments about collaboration with your local partners. So if I was to go into Bangladesh or to Pakistan or to India or wherever, I need to work with the local people who know what's going on. I need to put them in charge. I don't want to go around trying to get information from them or do this or that. I try to bring in the funding because our country is fairly rich and we can support some of these scientific endeavors. But it's really, if my partners in country aren't interested in it, it's not going to work. So the local people are sensitive to that. Absolutely, that you need community leader commitment towards that. And who am I as an outsider from the global north, as you say, to be that person? No, it's got to be my collaborator. I have always worked that way. I wish more people would work that way. If you are to go to another country, find your local partner and have them be in the lead. That's my main message.
Hello, my name is Seungmin, and I'm currently in Japan, and I'm graduating in 2024. So I experienced MERS and COVID, so I was kind of curious about the COVID viruses. So I've heard that SARS and MERS were there prior to COVID, and I want to know what role global health played during those kind of occasion, because it is very kind of hard to know what global health is doing for the normal people.
Yeah, so great question. Thank you for that. Turns out I was involved with the first pandemic, SARS. SARS was back in 2003. And as you know, it started in Asia. It was in Hong Kong and part of China. And then it started transmitting around. Japan shut down travel to those countries during that time. It was, so how was it global health? Well, here was a new infectious disease. We had never seen something like SARS before. And that stands for the rest of the group, severe acute respiratory disease. People with pneumonia, and they had a high mortality rate at the time. What's interesting, where it became global health, is that the World Health Organization polled and pulled together experts from 20 countries who had the expertise on coronaviruses, which this was, and they met daily. There was, back at that time, there was a lot of discussion as to how can we beat this? And actually they found isolation was the way to stop it. It was early in the disease. And so people were screened before they could enter another country. That is part of global health. But I always look at it as this huge collaboration of countries. They shared their scientific findings. There was no issue with patent rights and all those IP interests on that. So that's SARS. Then came along MERS, and MERS is primarily in the Middle East, right? And so it is carefully screened. It's caused by the same family of viruses as SARS-1 and SARS-CoV-2, because it's coronavirus. And MERS, actually, we were working on the MERS, collectively in the scientific field, working on the MERS vaccine. And then when SARS-CoV-2 came along, they were so closely related that the gears shifted to do a vaccine on SARS-CoV-2. But there's still work on the MERS vaccine. So it's all one family of viruses, coronaviruses, with little mutations in the different segments of the virus. And global health helps us understand by collection of all the science, the viruses, the sequences of the viruses, and the vaccines to enable us to understand the spread of the diseases more. Thanks for your question.
Well, Dr. Quinn, thank you again for your presentation and excellent answers to the questions. Students, thank you so much for attending, and your hundreds of thank you messages in the chat for Dr. Quinn.
Thank you very much. And thanks to everyone for tuning in. Appreciate it.